Thank you for joining us. You are a part of an elite group who recognizes that Black women's health should be at the forefront of the national conversation. We are mothers, daughters, activists, entrepreneurs, entertainers, corporate warriors, and more, who help boost the economy and often drive the national conversation. For 38 years, the Black Women's Health Imperative has strived to amplify our voices, help enact policy that protects us, research our issues, create programs that enhance our lives, and produce events like this one to ensure we keep the conversation going about the issues that matter to us most. So, let's get started with our program.
Welcome to Black Maternal Health Week 2022. This is the 5th year of Black Maternal Health Week, where we uplift and celebrate ways we are answering the call to make birth safe, sacred, joyful, respectful, and a liberated space for all Black birthing people, and we talk about a path forward. I am really so excited today to bring you the conversation and roundtable with Black Women's Health Imperative, Birth Detroit, and Birth Center Equity to share the origin stories of our organizations and our visions for Black systems of care and Black leadership in the liberation of Black birthing people. We are so honored today to sit at the feet of our elders and leaders and visionaries who have cleared the path and watch this movement evolve and talk with our trailblazers that are continuing to move us forward. So just an introduction, my name is Kanika Harris. I am the Director of Maternal Health for the Black Women's Health Imperative, and we are a national nonprofit organization dedicated to advancing health equity and social justice for Black women across the lifespan through policy, advocacy, education, research, leadership, and development. We are coming up on our 40th year anniversary. And this time we've worked tirelessly to identify our mission, which is addressing the pressing issues that affect the nation's 22 million Black women and girls, and investing in evidence-based strategies to deliver bold and new policies, advocating for health promoting policies as well. We believe that all Black women and girls should enjoy optimal health and well-being in a socially just society. So now I will introduce you to our moderator today, Leseliey Welch. She is a public health leader with a business mind and a visionary heart, holding love as a guiding value, a way of being, and action in a politic. She is a co-founder of Birth Detroit and Birth Center Equity, a mom and a tireless advocate for work that makes communities stronger, healthier, and more free. Leseliey leads a team of birth workers, birth advocates, and community leaders, planning Detroit's first freestanding community birth center, Birth Detroit, and is proud of the launch of Birth Center Equity to grow and sustain birth centers led by Black, Indigenous, and people of color across the country. Leseliey has nearly 2 decades of leadership experience in the city, state, and national health organizations. She earned an undergraduate degree in women's studies and master's of public health with a certification in women's and reproductive health and a master's in business administration from the University of Michigan. So I will turn it over to you, Leseliey. Thank you.
Thank you. Thank you so much, Kanika. It is my honor and privilege to moderate this panel today. I am so excited about both the theme and the folks we have here for our discussion. The theme of Black Maternal Health Week is Building for Liberation this year. Building for Liberation, centering Black mamas, Black families, and Black systems of care. The theme reflects the critical need for learning about Black feminist and womanist approaches in strengthening wellness structures within our communities across the diaspora as a revolutionary act in pursuit of liberation and the global fight to end maternal mortality. And I don't think that we could have a better configuration of speakers to talk about this topic today and about feminist and womanist approaches to leading our own liberation and our own care. And so with that, I am thrilled to introduce our panelists today. Our first panelist, Ms. Byllye Avery. I grew into a young Black feminist in women's and gender studies at University of Michigan, reading about you and your work. So it is an honor to be able to introduce you. Ms. Byllye Avery is the founder of Black Women's Health Imperative, formerly the National Black Women's Health Project, and the Avery Institute for Social Change. And she has been a healthcare activist for over 30 years, focusing on the specific needs of women. She is a co-founder of Raising Women's Voices for the Healthcare We Need, and a member of the Luminary and Be Well Health Expert Network. Thank you for being here today, Ms. Byllye. And next up, we have Dr. Karen Scott. Dr. Karen Scott is the Chief Black Feminist Physician Scientist, founding CEO and owner of Birthing Cultural Rigor, LLC, with more than 20 years of experience supporting women, girls, and persons across the sexual and reproductive life course in urban and suburban communities across the Midwest and California. She is an improvement and implementation scientist and activist grounded in Black feminist reproductive justice praxis, with formal training and experience as a community-based OBGYN and applied epidemiologist. Thank you for being here, Dr. Scott. And next we have Dr. Deanna Wathington. Dr. Deanna Wathington is a public health practitioner and family physician. She currently serves as the CEO of Common Sense Childbirth. Dr. Wathington brings over 30 years of practice and academic experience in the field, with emphasis on collaboration across multiple sectors to address and optimize community health, equity, and diversity issues. And finally, we have midwife Jamarah Amani, director of Southern Birth Justice Network. Jamarah Amani is a community midwife who believes in the transformative and healing power of birth and that every baby has a right to human milk. Her mission is to do her part to build a movement for birth justice locally, nationally, and globally. Will you all please join me in welcoming our esteemed panelists today? And before we jump into our first question, I would invite our audience members to please, as we go, type your questions into the chat. So we will be receiving and organizing your questions as we go in preparation for the Q&A period. And I also invite you to participate in the Twitter chat that will be going on at the same time as our discussion today. And the hashtag for that Twitter chat, led by Birth Detroit, is BMHW22 Liberation Stories. All right. Welcome, y'all. Let's take a deep breath and come into space together. I invite us to release every moment before this now moment and to anchor ourselves in our origin stories and our vision for our collective futures. And with that, I would love to address my first question to Ms. Byllye Avery. And just looking at the legacy of your work and how you've sparked a movement for women of color to become involved in defining our issues and leading in our own health. My question for you is, can you tell us about what inspired you to this work and about the origins of Black Women's Health Imperative?
Oh, thank you so much. I just want to start by saying I need to correct that paper you read from because it's been closer to 50 years than it's been 30 years.
Yes.
I wish it had happened in 30 years, but the second thing I want to say, it is so wonderful to see so many sisters working on our health issues now. And I just thank the goddess that I am
Mm,
able to live to see the day and to know that this work is going to continue for many, many generations to come. And you have to have no idea how welcome you are into the circle. Because when I started in 1973,
mm,
finding Black women to work on our issues were very hard. But we found the 5 or 6 that were there, and we all worked together and sort of kept the idea that there would be more, and to know that we were working to prepare a place for you
mm.
and that you would come and you are coming. And I am just filled with pride and I just almost want to cry. It feels so good. As we're thinking about births, I was thinking, am I a midwife or am I a birthing woman? I don't know which one, because in order to get to the Black Women's Health Project, the National Black Women's Health Project, and the Black Women's Health Imperative, I think I'm probably one of the few people in the world that's got these two organization things, that I claim, because they actually ended up being two different organizations, but we can talk about that later. But I want to first talk about my first baby, which was the Gainesville Women's Health Center, which was an abortion clinic. And that was the first baby that I either birthed or caught, whichever way you want to look at it. And it was really there that I started to learn about what makes us tick as Black women, and what's the difference between Black women's health and Black women's health, white women's health, I mean, and Black women's health, how we look at it, and how some of the same things we had the same list, but the priorities were very different. And we all know now with intersectionality and looking at the social determinants of health and all that stuff that all of you all learned in school, we figured it out the hard way before we had these fancy terms to give to it, that the lived experiences of Black women determine what were our priorities. And so I learned a lot at the abortion clinic. We were 50% of the women getting the abortions, getting the crisis care, but less than 10% coming in for the well woman care. And that's what I focused on. Why were we only the 10% coming in for care? Then the second baby I birthed or caught was Birthplace, which was an alternative birthing center with midwives, providing all of the services. And boy, was that fun. Oh my God. We got to develop the most exquisite services with midwives, that 1.5 hour initial visit and those 30-minute follow up sessions, and making sure the men were involved all the way, because the women at that time didn't get pregnant by themselves. And we involved the men just to dispel all that myths about them fainting and not being able to hold up. You ain't having the baby. All you're doing is looking at it. The least you can do is be here and be present, and involving the children and raising a generation of children who won't have to ask where the babies come from. And most importantly, giving the women the type of birth experience that they truly deserved, whatever position they wanted to be in, whether they wanted to have the baby in the bed, or whether they needed to get on the floor, or whether they needed to be on all fours. The only thing we required was one baby head first. We did not take any risk with women's lives. And so I learned so much about life. I learned about death by being involved in birth. I learned the importance of the breath. And little things like, there are a lot of babies born on their daddy's birthdays. Most of the women had labels just like their mothers. That intuition is really a thing, and Nancy the midwife would say to me, "Oh baby, oh Byllye, we're gonna have a baby." And I said, "Why?" She said, "You're nested." I said, "I am." Yeah, look at you. And then that baby would be born. And the fact that I remember one birth that just really got me when Nancy took a little nap for a few minutes, and she woke up, she says, "Oh, there's something gonna happen that we need to be careful about. Something's gonna happen with the baby's neck." And I started getting scared, thinking the baby's gonna be dead or whatever. She said, "No, no, no, Byllye, don't go there." The cord was just wrapped around the neck, and so she made it a practice of always reaching up, finding out where the cord was before the baby was born. It was just things like that. And I found the grand midwives who lived in the area, and I would go and sit at their feet and ask them what they did. And this is the last birthing story. I'm gonna move on. I just have to tell you, I could talk about this forever. And she said, "Yeah, I was at her house." She said, "Yeah, y'all got a birthing center over there in Gainesville." She said, "But I had one up here in Alachua County. I figured out that I couldn't go be with all my mothers that were coming at the same time, so I would tell them to come here." And they would come here and they have their babies, and then they would sit out in the sunshine on this porch, just like me and you. So, what's new, what's new is old again. What's old is new again, I guess the way the statement goes. And then the third baby was the Black Women's Health Project, in which I was just so upset about the poor health statistics that were presented in Health United States 1979 and put on the shelf, and nobody was doing anything about it. And so I set out to bring Black women together because I figured if we could get us together and people could hear about our health status, that we would figure out what to do. That I did not know the answers before I started, but I learned soon that I did not have to know the answers, that I could bring my sisters together, and together we would figure out what we needed to do. And you all know about the historic conference in 1983 when, as Linda Blunt says, 2,000 of my best friends came together, and we decided that we were sick and tired of being sick and tired, and we were going to figure this out. And because the head rules the rest of the body, we spent the next 15 to 20 years looking at Black and female. What is our reality? What is our lives? And being able to talk about those issues that we had never talked about: domestic violence, incest, sexual abuse, all of these things. How unsafe girls were in families, how
Yeah.
unsafe girls were. I just heard Alice Walker talk yesterday about how girls are unsafe in families of men. And that's not every single man, but there's a lot of men that it is. And I'm glad it wasn't my reality. I didn't have that, thank goodness. But if I hadn't learned about it being the reality for so many other women, I wouldn't have been able to do anything. And so therein lies the birth of the Black Women's Health Imperative, Black Women's Health Project, and the sisters have taken it and they are running with it, and they are doing a good run and fighting a good fight. So I'll just stop there.
Oh, thank you so much. And we can listen to your stories forever. So thank you, thank you, thank you. And there's so much power in our stories and so many stories that remain untold, I think, in our communities. And so I thank you for that. And the idea of what is old is new again. And what is happening with the movement to uplift midwifery in our communities. I want to go to midwife Jamarah, Amani, and just to acknowledge, in keeping with the theme of this week, the centering of Black mamas and families, that Black midwives have historically centered Black mamas and families in all of the ways. And so, Jamarah, what do you want our communities to know about the role of midwives in building for liberation today?
Well, thank you so much for having me on this panel and for that question. I'm absolutely fangirling over here over Queen Mother Byllye Avery. And I love hearing the stories. I could sit in this whole hour could be just you telling stories, and I would just be hanging on your every word. I've literally walked the path that you've paved. So I just personally want to say thank you as someone who came up through the reproductive justice movement in Atlanta and then moved to Florida to become a licensed midwife. I worked at the Florida Traditional Midwifery School. So I've literally walked the path that you've paved.
Oh, wonderful.
Yes. And so, you know, through my work, I've really explored this history, herstory of Black midwifery, and we absolutely know that birth justice is Black midwifery. And what we are doing really is reclaiming that legacy that Black midwives have left for us and trying to integrate that into a very toxic healthcare system, which is divorced from midwifery. And we can just trace the trajectory of how that happened through the policies that were enacted and the campaign against Black midwives in 1857 by the American Medical Association, in 1921 with the Shepherd-Towner Act, and how that, you know, literally pushed and marginalized Black midwives out of their communities, and that we really start to see the decline of the health of our communities when that happened. And so we cannot leave Black midwives out of this conversation at all. We have to center Black midwifery in order to center Black families. And we have to give Black midwives, Black student midwives, the support that they need in order to serve families. And that's really the work that I'm doing now through National Black Midwives Alliance, is supporting Black student midwives and building the Black midwife workforce, and really advocating for resources so that we can shore up our workforce, so that we can, you know, expand it, so that we can, you know, push this Black midwives model of care, which is something that we've developed through National Black Midwives Alliance. There's 21 things that I've identified as being central to the care of Black midwives, and all of those things need to be integrated throughout our healthcare system. And those things involve, you know, building trust, making space for different configurations of families, making sure that we are paying special attention to the social determinants of health. One of my early midwife teachers was Mama Saran Henderson in Atlanta, Georgia. I precepted with her back in 2007, 8. And she really taught me about the importance of foods and food justice, and, you know, providing that to the families, and would literally pull collard greens from her garden and give them to her clients. And that's been a part and parcel of Black midwifery. Also, you know, really uplifting inclusion. So making sure that we are centering young mamas and immigrant families and queer families and transgender birthing people. Like, all of that really, really matters, because when you look at the legacy of Black midwives, and I like to think of Mama Biddy Mason as one of my sheroes and inspiration, who, you know, was an enslaved woman who freed herself and then went back to free others. And then also, you know, established a midwifery and nursing practice. She became a millionaire, founder of the AME Church, and we can look at all these wonderful things about her history, but Black midwives really being pillars of their communities and providing for the least of these, right? So going to the prisons, she was known for going to the prisons and finding people there that needed food, that needed care, caring for indigenous families that were coming over the border, because she was in Los Angeles area in California in the 1800s. So that's just been a part of midwifery, this, you know, caring for families who are marginalized and uplifting that, making sure that our care is culturally centered and relevant. Black culture is not monolithic. You know, we've got our Muslims and our Rastas and our Christians and, you know, our Caribbean people, our, you know, continental African communities. Everybody needs different types of care. People need care in their own language. They need care that honors their culture and their values. And that's really central to the Black midwives model of care. So the more that we can uplift that, the more that we can make sure that we have funding for cultural programs, that that we're centering families in, you know, the construction of neighborhoods. All of that helps to improve maternal health. It helps to bring about birth justice. And I'll just say one more thing, another project I'm working on, and how we integrate this concept of Black midwifery back into hospitals. Hospitals where there are large populations of Black people giving birth, we really need to make sure that the policies of those hospitals are the most respectful as possible for the people that are birthing there. So that means that midwives should be the people attending births. We see here in where I am in Miami, Florida, our largest hospital system here, there are midwives there, but they're only in triage. They're not doing births. And so birthing people don't have access to a midwife, in their birth care. And also, making sure that those hospitals are centering informed decision making and shared, that it's a shared partnership process, that we're not just going to do something to your body, but we're going to talk to you about it, and we're going to give you an opportunity to ask questions and make a decision for yourself, because upholding bodily autonomy, as you mentioned, Mama Byllye, about making sure that folks can move around and squat and get on all fours and do what they need to do, because our own intuition about our bodies is it's energetic, it's ancestral, and it's a human right to be able to have bodily autonomy at all times. And so many hospitals are denying that to birthing people. So I'll stop there, but that to me is all the, some of the things. There's 21, I won't say all of them, but that's many of the things that are central to me for the Black midwives model of care.
Oh, thank you so much. And I think we can make that available to our audience as well, so that they can see all 21.
Yes, it's on our website, blackmidwivesalliance.org/resources. You can download it. It's a PDF. Thank you.
I will move my next question to Dr. Karen Scott. And when I think about this question, I think about in myself in public health and doing public health work for a really long time, and this assumption that was made that increased access to systems of care not designed for us was somehow
going to help
our outcomes. And it just seems absurd, right? And so I know that you made a transition out of the hospital-based practice into quality improvement. And so I'm wanting you to please tell us about your journey and your work in the world now.
Thank you so very much. Thank you, all of you all. I have been getting teary-eyed because the person who inspired me to actually pursue my MD is on here, and that is, Elder Mama Byllye Avery, because I actually wanted to get my PhD in molecular biology. And it wasn't until I was 20. I never wanted to be a physician. I did not want to be at the bedside. I loved science. I did not, at the same time, I also grew up poor in East Nashville before gentrification in the South. My mom was, at the time, with the statistics in the 70s, 80s, a single Black female had a household. So the whole Reaganomics, welfare queen, like all those tropes about Black women, we lived one step above the projects, across from a prison. There's a whole narrative about our experiences, but our experiences were exploited by the systems of care to make it look like we were biologically inferior, unfit, to birth, to parent, to love, to serve and nourish our own children with our own bodies, when we nourished and fed the whole nation. So I took all of that to college with me, but then also thought I was going to get a PhD. And in biology of female sexuality, reading our bodies ourselves, I have to give credit to my feminist white plant physiologist, Ren Edwards, who introduced me to the work of Byllye Avery. And it was at that moment I was like, as Elder Avery was saying, we looked at the statistics, and I'm like, wow. And I'm also a Trekkie. The final frontier was medicine, to continue to demonstrate there was the evidence that we were continuously being killed in our own systems of care. That is why I pursued medicine. And MD was to have a voice and authority to change and transform delivery models for Black women and girls. That is not what physicians do. And so I did not learn that until I'm already in medical school with loans, my intern year of residency. And I wanted to quit, not because I had failed an exam, not because I didn't pass my boards. I just didn't feel that I was doing the work that I set out to do at 20, when I said I wanted to transform healthcare delivery models for Black women and girls. And I can say that as a board certified OBGYN, we aren't transforming healthcare delivery models for Black women and girls in a way that is humanizing or dignifying, or honors who we are. It prioritizes I don't even call it our pathology, it pathologizes our humanity and our existence. And even as I continue to advance through residency as an attending with this career, I continuously felt in my soul that I was violating my own sense of ethics, my own sense of commitment to community. And I struggled emotionally every day trying to perform being what everyone else around me loved being, which was a US trained OBGYN. And there are very few moments in the last 20 years that I can say that I enjoyed it, to the sense that I didn't feel I was always fighting not only for my dignity, but fighting for my dignity is also fighting for the dignity of others in whom I serve. And that is not what I am trained to do as a US OBGYN. So I quit April 16th, actually during Black Maternal Health Week last year. And I quit after I can build capacity. I've gotten over $2 million of funding. I brought nurse-learning partnership to Chicago South Side. I believe in nurse-led and midwifery-led models of care. I believe in doulas. I believe in lactation consultants. Like, that's how I was trained in my community program. But once you get out into the world, all the things that the system claims they want from you, right, to get you in the system, is really to break you down so that you actually don't have any to give back to yourself or to your community. And I was tired of fighting. I mean, my chairs, they're probably watching. I'm tired of fighting chairs who are white men, white women, Black men, Black women. I've been told your passion is going to burn bridges. I'm like, well, if those bridges are of oppression, then burn, baby, burn. Like, I am not here for your liberty. I'm not here for your advancement. I am here for the sovereignty and sanctity of my community. And because that is innately who I am, I philosophically could not practice obstetrics and gynecology in its current form. And since we know we are the original eugenicists, I was birthed into RJ in 2010, 4 years after I completed residency, and that changed my life. It gave me the language to understand why I struggle so much in being an OBGYN, until last year, 2021, another Black woman OBGYN said, have you forgiven yourself for not becoming an OBGYN, but for staying one? And I was like, that's it. So what I bring to the quality improvement, implementation science, practice and research field is I am a Black woman. Jessica taught me that, period. I am a Black woman. And with that, and a Black feminist praxis, I am building both patient, community, and hospital capacity, right, to not only acknowledge our lived experiences, our intellectual thoughts, our political activism, but to translate our own wisdom into the ethics, the leadership, the science, the measurement selection and strategies, the community partnerships, which is participation that has been, right, exploited, extracted from, experimented upon, almost erased. And I can't continue on that path anymore. So I built a Black woman-led quality improvement, implementation science practice and firm. It was my Black mental health therapists and my Black women funders who told me, like, leave. I spent 2 years in academia, the worst ever. It's not for me. I can't be complicit not only in my own destruction and demise, but that of my people. That sticks with me. And so that is why I left. But I left with the support of funders, with the support of community, with the support of partners, so that we can redesign the very ways in which our systems of care are evaluated. So I don't do studies where white women are the control and Black people are the other. We are the control. We are the standard. We are everything in between. I believe we need to understand not understand, but celebrate our own diversity, our own heterogeneity and richness of our culture, of our community, and what that looks like in science. And so that is where my work and my lies is, that I feel I am more aligned with with my own purpose of transforming healthcare delivery models by informing the very tools and trainings and techniques by which have been used to, right, they have been used to control the narrative that we were broken people, and we're not. And I also come from a place of an unapologetic and authentic love and admiration for our people. So the work that I do is different, right? When I start my trainings, or my presentations, I don't start from a place of what I call data porn, right? Like I don't continuously talk about we are dying. I say no, hospitals willfully watch and observe as they contribute to our deaths and dying. And that's very different than saying Black women are 3 to 4 times more likely to die. No, hospitals are 3 to 4 times more likely to kill us.
Yes.
That is a very different statement. We don't walk into a hospital checking off a menu of hemorrhage, ICU admission, blood transfusion, heart attack, stroke, having our babies torn not only out of our bodies abdominally, but just from our hands. Like we have stories of Black fathers where white nurses took their babies out of their hands because that's not the type of skin to skin that we support.
Yeah.
So I listen to our community, and then I apply a Black feminist praxis to our ethics, to our theoretical frameworks, to our methods and methodologies, to the science, so that when there is a measure like our patient reported experience measure of obstetric racism, I went to Black women. I went to Leith Mullins and the Sojourner Syndrome to explain what's happening, but also to talk about our resistance and our resilience. I went to Deanna Davis and obstetric racism, Harriet Washington's medical apartheid and adapted reproductive and perinatal apartheid, right? So just being us in the work. So what does it look like when Black women and gender expansive people are leading the quality improvement, are leading the implementation science, meaning leading the ways and creating the standards by which we evaluate the system, and then determining the data that is used to then create the policies and practices for adaptation or implementation. That's where I feel my power lies, and I can be of better use than trying to continuously torque myself to be a US trained OBGYN.
Yes.
And I thank all of you all for who you are and what you do. Because we are necessary, and we in community, we are so needed to see each other do this work and to support each other in this work, and our healing as we do this work when we are hurt or harmed by the system.
Mm-hmm. Wow, thank you, Dr. Scott. And I just invite all of us who need a breath to take a breath. I think when we talk about harm, we so often talk about harm in ahistorical ways and as if there are no perpetrators. And that's problematic. And so I thank you for raising that in this time. And with that, I want to bring Dr. Deanna Wathington's voice into this space. And my question for you to get you started here is, how has your work evolved over time with systems transformation in mind?
Okay, well, first of all, can I just say that my soul is so full right now. Just to be with all of you in this space, but also to hear the resonance among us and the strength within that. And of course, it is always my pleasure. And Byllye, you know, I'm going to call you Auntie because you're not old enough to be my mom, but I love you and thank you for your guidance. Our Bodies, Ourselves in my teenage years in the 70s, the Black Women Health Project when I was obtaining my MPH in the 80s, and just sustaining me through the craziness that is medical training after that. So you are a light, and thank you for lighting all of our candles and making us stronger. I also just wanted to say that, ironically enough, when I leave this session, I'll be going to attend a community session near Midwife Mary Johnson's house, Midwife Mary Johnson in Orlando, who also had a birthing center here and delivered many, many, many thousands of babies at her home. Well, you know, the origin story for Common Sense Childbirth is an interesting one. So everyone knows Mama Jenny Joseph, And Jenny is a British trained midwife. And when she arrived here in 1989, she had, been trained as part of a system of care that was collaborative, part of a team. She was hospital trained, and she expected to see that here. Um, of course, those that were training within the system at that time knew that that was not the case. And so she actually began her story here in the Orlando area, providing home births and some clinical care. Over time, though, quickly, she came to realize that the care that was being provided, if you want to call it that, for women of color was markedly different, as were the outcomes. And she was dismayed and appalled. And so she actually then opened her own practice and helped other practices in the area. She is, as everyone knows, a fabulous midwife. And so in the beginning, her efforts were really focused on trying to make a difference within this community. And then she eventually grew to become part of the licensure movement here in Florida, and not in a suppressive regulatory way, but trying to create access for all midwives, licensed midwives, certified professional midwives, and CNMs here. I think that it's pretty clear that through the years, she's had very consistent outcomes, right? And so what she's seen over the 32 plus years of her practice is the ability to actually erase all of these negative, disparities, the data porn, as Dr. Scott refers to it, from our practice, the women in our practice, and actually even elevate the status of the women who were not of color in our practice, which is what all of us have been saying for the longest time, right? If you elevate the status of the people that you're marginalizing, you elevate everyone's status. And so out of that, though, for any of you who knows Jenny, she is a great midwife, and she loves to catch babies, but she needs to have a voice. And so she and I had been interacting over many years. And so she's been involved in policy, as you know, the Momnibus, which we just recently had another policy ratified by the National Black Caucus of State Legislators that is on its way up to Congress, regarding midwives in the community birth infrastructure, which I'll try to talk about more in a minute. We've all been talking about it, actually. And felt the need to establish a task force that was national of the women and the providers and the community health workers, and just the community birth workers who think like us and are aligned with us. And so after she began the task force, it's now grown into the School of Midwifery as well. So in fact, now over these 30 years, what we have at this point are 4 divisions. We have our health services division, which is the birthplace, right? So that's our birthing center for any and all, every person, every time. That means that we treat every person the same every time, and we don't care your insurance status, your documented or undocumented status. None of that matters to us. We just want to help you and your family have a healthy baby. We also have the Easy Access Clinic. And in that clinic, those are women who are choosing to have their babies within the hospital, but they still want to be exposed to Jenny's model of care, right? And so that model of care that she developed, that we're applying in health services and everywhere else, actually, is called the JJ way, right? And you've heard her speak on that many times: access, connection, knowledge, and empowerment. And it infuses everything that we do, including what people now call wraparound services that we were doing, 30 years ago. But more importantly, what's within that system, of course, is respect, care, authenticity, integrity, right? And cultural relevancy, cultural humility, really, because this cultural competency piece that we learned, out in the field, Dr. Scott, it is not a box to be checked. We all know that, right? That's an ongoing piece of work, and there are people who choose not to work on it. Okay, so having said that, our first division, health services. The second division is our School of Midwifery, and we are the only Black-owned School of Midwifery in the United States, nationally accredited by MEEC and by the state of Florida. We have an incredibly diverse student pool, but of course, the majority of our midwifery students are Black women, as is intended. And we are proud to be a part of contributing to workforce development and then sending them out to Jamarah to become part of the alliance. So thank you for that. Our third division is the Common Sense Childbirth Institute, where we're actually providing community education. And so for that, doulas, perinatal educators, lactation specialists, right? Community health workers, everybody and anybody who wants to be part of the community birth infrastructure and serve within their community and be a safe place for our women and their families, for our birthing people and their families. We are providing that education. And then our last arm is the National Perinatal Task Force, which I referred to before, which we're now coming up on about 170 perinatal safe spots across the nation. Anyone can be a perinatal safe spot if they're engaging in the JJ way of practice, and they provide safe, respectful care to all women, and particularly women of color and Black women, period. And so we, within that, we're actually now looking at and have established in the last 8 months or so 2 perinatal safe zones, because perinatal safe spots are not necessarily geographic, right? It could be a lactation specialist who practices the JJ way. She's just on her own, and she may even be doing that partly in a hybrid manner because of COVID, right? But perinatal safe zones are geographic areas where we have a gathering of perinatal safe spots who come together in a collective care model, right? And provide a safety net over that area. So right now, we have one of those in Austin, Texas, and one here in Central Florida. And we have about 2 or 3 more ready to launch in the next year, but we shall see. But more than that, how in terms of transformation of the system, I think we needed to build those building blocks first to do that. So now our mindset is that we believe in a community birth structure, right? We believe that the people in the community are the best folks to serve that community. They're already culturally relevant. They already can provide respectful care. And that what we want to see is that they are supported financially. So we've begun the process of micro-granting, fiscal sponsorship, investing in our communities, our practitioners, our educators. We feel that's most important to sustaining. And to be honest with you, we're not really interested. How can I say this? I know people talk about assimilating or sometimes integrating. We're coming alongside, really, with a system of care that we know works. We have all the data, we have all the research. We know that it has worked for actually hundreds of years, right? If not thousands of years. So we know that this works. We are trying to create a better system. We're trying to disrupt. And actually, that is our mission statement, to inspire and affect change through disruption of the maternal and child health systems. So that's where we sit. Sorry, talking.
No, it's wonderful. And thank you so much. And we have just a minute or two before we should be beginning our Q&A. And so what I would like to do is give Mama Byllye Avery a final word in here and ask, what does liberation in Black maternal health look and feel like to you?
Oh my goodness. The ability for women to make a decision when and where and how they want to birth their babies. That is liberation. Not being pressed by, do I have enough money? Not being pressed by what this regulation over here says. Not being pressed by any of that, but just to be their full selves and feel what it's like to be free. You know, Nina Simone says, I wish I knew what it was like to be free. Well, I can't think of a better time to be free than is with you or bringing new life into the world, and to know that you're bringing life into a world that is deserving of what you're bringing. I
Yes.
think that to me is liberation.
Oh, thank you. Thank you, thank you, thank you so much.
Mhm.
All right. We have a variety of questions from our audience, and what I will do is field them and direct them. And so I'd like to start with this first question and asking midwife Jamarah Amani is a question that asks us, what can we do to better nourish our mothers and families through preconception, pregnancy, birth, postpartum, and beyond?
I love this question. That's what it's all about, is that nourishment. And I think if we're doing that, we will erase, many of the health disparities and challenges and complications. So it has to start from birth. Again, my teacher, Mama Saran, always says liberation begins with birth. So what are we doing for how we're bringing these babies into the world, right? What does their initial experience look like? Is it gentle? Is it peaceful? Is it welcoming? Who's in the room? Are the people in the room people who genuinely love them and care about them, and love and care about the communities that they're from? Because we take care of, birthing people, right? But those birthing people are part of a family, they're part of a household, which is part of a community. So are the providers that are in the room also part of that community? Are they also nurturing that community? Because that really is how we are going to begin to look at nurturing people, is by nurturing community. So it's got to be about systemic change. And then what are we teaching folks about their bodies? As that baby that's born in liberation then should be raised in liberation, free Black children. So looking at our school systems and are we teaching people to know and understand themselves and their bodies? Are we teaching them, actual history and herstory? Are we, teaching them that they can be their full selves and not have to check any part of themselves at the door? I live in Florida, where they have just passed legislation, which is called the Don't Say Gay bill, where they're not supposed to teach at all about, who I am as a queer woman. And I'm very concerned for my children and the type of messages that they might get. I'm also the parent of a transgender child. And so I get very concerned about, what messages children are getting as they're coming up. So are we creating environments where people can be whole, whether those be schools or churches or community centers, et cetera? And when you look at the Black midwives model of care, you'll see that in there, that it's really about nurturing the entire community. That has to be a part of it. That's how we nurture people. And then I think about, the main challenges that we're having within the maternal healthcare system specifically is about, institutional racism, and how, medical providers are trained to really, as Dr. Scott said, pathologize our humanity. And that has to be reversed. It means we have to really pull out the foundations of medical education in this country and redo it, just start it over. And it's got to be centered around, if we have the murders of Black women occurring at 3 to 4 times the rate of our white counterparts, then that means there should be 3 to 4 times the resources invested and 3 to 4 times the amount of providers. We should really be measuring things along those lines, because, they love numbers. So let's talk about the data in our own terms. And I love the way that Dr. Scott is able to just articulate that so beautifully every time. The next challenge is the rate of interventions, right? So things that people don't want. Nobody goes in saying, I'd like an episiotomy, a forceps delivery, and then a C-section. Nobody goes in saying that, right? So honoring, making sure people have the tools to make holistic birth plans, and then honoring those when they go in for their care, or when they, and then we talk about increasing home birth and birth centers. But in order to do that, we've got to train the providers to be in those spaces, and then we have to resource those spaces. So really shaking up those dollars, and we need billions to do this, because the number of providers, we have less than 2% of birth centers being owned by Black midwives. We have only 7% of midwives in the United States are Black. So we've got to really, really shore up our workforce. And then lastly, it's really about the integration. How do we bring doulas into hospital settings and birth centers and homes, making sure everybody has a doula or birth companion, however, whatever term you want to call it, but that holistic person that's going to be the hand holder and the coach and the advocate. And then making sure people really know about their birth options. I live in a state where home birth is covered by Medicaid, but most people don't know that, and therefore don't have access to that type of service. So that educational part really matters as well.
Thank you so much. And our next question, I'll invite Dr. Karen Scott, is about accountability in our health systems, hospitals, and clinics. How can we make hospitals and clinics accountable for the type of services they provide?
Thank you for that. I just love the space. So one of the ways, right, for accountability, right, one of the ways I believe is evaluation, but I also believe, I don't believe based on my current experience, right, because I have now a novel and valid measure of racism in hospital-based obstetrics. It was published in Birth 2022, March 18th, without revision in its original form. And you would think hospitals would be ringing, emailing us, because it was always about the rigor, which we know is a dog whistle for saying we don't like Black-led anything because it's not rigorous. And so we had a Black woman-led, predominantly like 99% Black team. It's one of the most scientifically and culturally rigorous measures. So it was never about the rigor. It is about the fear that when you utilize this measure, then those who are in power and have been incentivized to harm, hurt, and murder us will be found out. Because this measure not only is about the experiences of those who are carrying the greatest burden of death and dying, but we have a timestamp on it. We can count back to when these reported experiences of obstetric racism are happening and the magnitude. And so we need measures that reflect our experience. And when it reflects our experience, usually because we let them and used theories, right, that honor our humanity. So our measure, our Primo scale, looks at the lens of racism through the experiences and words and feelings of Black mothers and birthing people. Our measure looks at how systems disrupt kinship. There's no kinship measure in QI, because it's always been about, right, the policies and practices. It's been to protect the system. Well, we utilize a measure where the patients get to use their experience to give the system a diagnosis of obstetric racism. And I invite health plans, I'm going to name them, the Joint Commission, the Office for Civil Rights, the CDC, CMS, Blue Cross Blue Shield, Aetna, managed care companies. You are looking for measures of accountability and key performance indicators, but you have to make the experience the outcome and not the outcome only. Like, we can't only look at rates of phenomenon, because we had a Black mother birthing person who had a full-term baby, a vaginal birth. The baby latched well to her body. The baby didn't require an admission into the neonatal intensive care unit. So by traditional QI standards, that would be a high-performing hospital. The health plan would be so proud to reimburse that. But when we made the experience the outcome and the standard, that same woman said, who only had a laceration or a tear, though he put me back together, I still don't feel whole. If you are standardizing metrics that don't illuminate our humanity, our kinship, and the anti-racist, anti-Black racist and misogynoir that's just embedded throughout our system, we can't hold things accountable. We're holding systems accountable to measures that they created, to meanings of harm that they created. When safety is defined as the absence of an adverse event, then that woman would not have been, that care would not have been seen as unsafe. But when safety is defined as our Black mothers and birthing people defined it as love and protection, then that was an unsafe vaginal birth, which can be unsafe. So again, changing the science, the leadership, right, the ethics, the measurements, linking our tools that we create, that we have. Like, I think about Elder, why am I blanking on Jackson? Oh, I'm talking about Atlanta. The researcher. Like, we have We have
Talking about Miss Fleta Jackson.
Yes, I was like, Elder
Dr.
Jackson.
Fleta Jackson.
I was like, I cannot. So like we have measures that we have created, our elders have created, we have now created and enhanced those, right? Those portfolio of measures. Health plans standardize the measures that our own communities created to evaluate the harm as defined by us, but also the solutions to mitigating those harms. We also can evaluate our own work. And when we evaluate our own work, we aren't comparing ourselves to all white institutions. We are just comparing ourselves to each other and the shared ethos or ethics that we have. That's how you hold people. Thank you for accountable. It is having health plans hold hospitals to recognize, and they are, I'm just going to say it, they are paying for our murder. They're incentivizing our murder. And so we change the standards of care and then the metrics of care and link the metrics of care to reimbursement, then we can call our hospitals and say, are you going to continue then to incentivize our ongoing murders, the ongoing grief and loss that our communities bear every single day? That's what I would do. Tie the impact of the care to the dollar bill.
Tie the impact of the care to
and like and what
bill.
Jamarah said, the meet us where the inequity gap is. It doesn't make sense to just give us $2 when we're saying in some states the death gap is 8 to 12 fold. Then we should have 8 to 12 fold the resources to try to undo what you did to us.
Absolutely.
Right? That's part of it, but I do believe health plans need to also come to community, like Black women, Black people-led researchers, and invest in our tools, and then hospitals accountable to our tools, to our standards. And then you can see the breadth and depth of harm, but also the potential promise of how we are healing ourselves outside of systems that millions of dollars are being wasted on, right? Invest in us.
Invest in us. Invest in us. Invest in Black systems of care. Invest in us. Oh, thank you so much. I am going to combine a couple questions into this last question, recognizing that we have just about 8 minutes left. And so I'll pose it first to Dr. Deanna Wathington and then to Mama Byllye Avery. And that question is, how can we as Black women collaborate to shift the paradigm and change the narrative around birth in our culture?
Well, Mama Byllye, did you want to go first?
No, you go first. You go first.
Okay. Well, I think that you see it being, you're visualizing it right now. And for most of this week where we come together from these different spaces and think about how we build it and make it better, to me, Leslie. What Karen just shared with us, which I was aware of, is something that should be in, yesterday it was, right? The announcement about the birth-friendly hospitals and the new updates coming out of Vice President Harris's office. Karen's measure should be the measure that deals with that. And what Jamarah brought to us, just first of all about your advocacy and action with the Black Midwives Alliance, but then also about our state. I live in this state as well. So coming from those policy and advocacy pieces and workforce development, I think that we have to give each other the same that we are asking that we give to patients. And so we've actually incorporated as part of what we do and how we live, that we extend that same respect, care, love, integrity to our providers and our community birth workers across the nation. And that's why we've instituted this collective care model, where we're checking in on each other and we have resources for each other, and we're trying to continue to provide that. So it gives us an opportunity to network, but also to be each other's, safety net and ear and venting spot and, whatever else we might need. So I think that's a beginning, I'm sure.
I think that one of the things, thank you for that. And you're absolutely right. Another thing we have to do is get into these seats of power and take a folding chair so that you can get at the table and start talking to the people who are making these decisions or challenging them. See, they're not being challenged. They're not hearing the Karens of the world. They don't know what Dr. Scott has to say. They not heard that yet. And it's not going to be a walk-in. You can't go there first time and think you're going to get what you want. The first time, they're going to say, no. Blah. I mean, people don't want to give up power. And so we got to get in there and get our feet under the table and get ourselves in the position so that we're helping make these decisions at NIH and all of these other multi-letter national government spending organizations. I love the idea. If whatever percentage we're disadvantaged, that's the percentage we need to be funded, And what I'm saying to people these days, for states like Texas and Florida, and all of these states that's going so heavily against women having the right to abortion, for every abortion that's not had, there's going to be either a miscarriage or a birth. Okay? We've got birth deserts all over this country. Politicized birth. You saying we can't have abortions? Okay, well, give us birthing centers, give us midwives, give us doulas, give us call these people on their stuff.
You can say whatever you want here.
Yeah, you say you care about birth? Okay, well, this is what it looks like. You care about life? This is what it looks like. If a woman is going to be forced to have a child, then she needs support to get that child all the way up through high school and into college or into a trade or into whatever it takes. And so I think we need to make birth the political act that they are forcing us to, and use this as an opportunity to get rid of birthing deserts. We shouldn't have that, shouldn't even be a concept, And the food thing, it's like when I was first traveling with the Black Women's Health Project, I was in Albany, Georgia, talking to these Black folks, and I said, Black infant mortality is a problem. This man said, ma'am, excuse me, I don't mean no disrespect, but I thought it was because our babies are dying because the women don't have enough food to eat. They don't have proper shelter. They don't have good care. He said, these are the things that's causing the babies to die. And you know what I said to them, ma'am? Thank you very much. You are absolutely right. And I'm never presenting this issue again without pointing up, these are the things that we need. That's in 1981. This man stood up in the back of this church and said to me, and I listened to him. He's absolutely right. So in these food deserts, people need transportation. We need places. We need midwives. We need doulas. And the midwives take care of everything that needs to be there. That's what we need to stick to them on all of these states that's got these repressive laws. That's what we need to do. Politicize it.
Politicize birth. Liberation begins with birth. We heard that. We heard how can we create environments where people can be whole. And I'm hearing you in your remarks, Mama Avery, say centering the Black midwife.
Absolutely.
Care systems. And so with that, one of the questions that we did have was, how can co-conspirators and supporters support our work? And I know that Jamarah wants us to invite people to please become an allied member of the National Black Midwives Alliance. And you could do that at blackmidwivesalliance.org. So please do support the work of the National Black Midwives Alliance. Please do take a look at and support all of our organizations as we build toward liberation together. And so we are at perfect time. I hate to end this conversation. It's been so rich and so wonderful to be in this space with you. And so I would like to personally thank Mama Byllye Avery for being here with us today, for your stories, your sharing, for preparing a place for all of us. Thank you for being here. I would go next to thanking Jamarah Amani, midwife Jamarah Amani, for being here with us. I love that you said, I've literally walked the road that you've paved. I thank you for walking the road that Mama Byllye paved. I thank you for the road you are paving for so many other Black midwives to follow. And I go to thank Dr. Karen Scott for your work and for telling the truth in such a powerful way today. Thank you for that and for centering Black feminist approaches to this work. And I thank you, Dr. Deanna, for being here today. I thank you for, all the work you've done in the public health space. I just want to lift that up, and for the work that you are continuing and moving to do with Common Sense Childbirth and investing in changing and transforming our systems of care. Thank you so much to each one of you for being here. And finally, thank you to all of our panelists, our participants, and our support that made this conversation possible. Thank you all for being here. I hope that you have been inspired today. I hope that you have come away holding something in your heart that you can do to help move our work forward and to transform our systems of care for the better. Happy Black Maternal Health Week, everyone, and thank you.